Hello, I am Asif Irfan and we are going to discuss history taking and clinical examination of the patient. History taking and clinical examination are the basic tools of a clinician to reach a diagnosis. So a good clinician is one who is well versed in history taking and clinical examination. As far as the history taking is concerned, it starts with the basic biodata of the patient. That is the name, the age, the sex, a complete mailing address, and the occupation of the patient. Occupation being important with reference to the occupational diseases that we have got. And then we come to the next section, which is the history of the present illness. The history of the present illness is the problem with which the patient came to the doctor. And the important point regarding this problem, regarding this section, is that it has to be arranged in a chronological order. For example, you have a patient who started with having cough 8 days prior to admission, and then he started having fever 6 days before admission, and this was followed by right lower chest pain 3 days before admission. So according to the chronological order, on the top would be cough for 8 days, next would be fever for 6 days, and the third would be complaint of right lower chest pain for 3 days duration. Once this section is over, you have the next section, which is composed of the history of the present illness. And this history of the present illness mainly tells you about the history which is relevant to the presenting complaints. For example, this patient, he had also a history of cough and expectoration during the winters, and these cough and expectorations were at times punctuated by episodes of fever, and he was hospitalized once the last winter. So in this context, this is important, and with reference to the presenting complaints, we come to the conclusion that this gentleman probably has got some sort of chronic obstructive airway disease, and the present complaint was just an exacerbation of the chronic illness that is going on. After the history of the present illness, there is the section in which you review all the other systems, and you look for any significant positive complaints relevant to the other system. And so what you do is you quickly go over the major common problems of different systems. For example, take the respiratory system, in which you would like to ask the patient about cough, hemoptysis, chest pain, and such sort of things. Then in the gastrointestinal system, you would be comfortable if you ask the patient about history of nausea, heartburn, dyspepsia, history of diarrhea, weight loss, and that sort of thing. Then in the cardiovascular system, important complaints can be complaint of cough, complaint of orthopnea, exertional dyspnea, PND, and history of hypertension, ischemic heart disease. These are the usual questions. If you want to review the CNS quickly, you would like to ask for a history of ataxia, history of dizziness, vertigo, and some localized or generalized weakness. And in this systemic review, you would be able to pinpoint which is the system at fault. And if there is some problems with other systems, you can go deeper into the complaints. Once this section is over, you would like to go into the past history of the patient, because that is also quite important. And in the past history, you would like to exclude some major diseases, medical illnesses, like you would like to take history of diabetes, hypertension, ischemic heart disease. You would also like to ask the patient for any history of jaundice, and all these things, any history of admissions due to any medical problem, and they have to be all in a chronological order. More important is the point that diseases which are recurrent, they should also be asked. For example, if you have a patient who has got bronchial asthma, or you have a patient who's got epilepsy, these are the things you should make out in the past history, that whether the patient has got any such problems. Then in the past history, you would also like to look for the surgical history of the patient. And in the surgical history, you would like to ask for some operations, when they were done. Obviously, I mean, you won't like to make a diagnosis of acute cholecystitis if you have the history of cholecystectomy. History usually deals with problems that are genetically transmitted. And obviously, you cannot ask for all the genetically transmitted diseases. But you have to be relevant. I mean, for example, if a patient comes to you with bleeding from multiple sites, you would like to ask the patient about any history of a bleeding disorder which has been going on in the family. Similarly, whatever was the presenting complaint, you have to ask the family history according to that. Another section is that of the personal history, in which you would like to ask the patient about any specific habits, like being a vegetarian, or any history of smoking, addiction, and especially in the case of the females, you would like to know about the menstrual cycle of the patient, and whether they were regular or irregular, or there was any abnormality related to that. So once you have taken the history, a good history, you should be able to pinpoint the system which is at fault. Whether it's the cardiovascular system, is the respiratory system, is it the GI tract, or CNS, or whatever. So a good history should be able to direct your physical examination accordingly. Starts the moment the patient walks into the clinic. The gait of the patient, the face sheets, the color of the skin. You can gain a lot of information by simply looking at the patient if you have got an observant eye. The general physical examination is composed of two parts. The first part is the compulsory part, in which no matter what your diagnosis is on the basis of history, you have to look for certain points which are compulsory. And then there is an optional part which changes according to your diagnosis on the basis of the history. For example, if you have a patient who's got some problem in the cardiovascular system, you will have to stress on looking for splinter hemorrhages, osseous nodes, Janeway lesions, the blood pressure, the JVP, the pedal edema, and sort of things. Similarly, if the respiratory system is at fault, you have to look for some other points which are more specific to the respiratory system. First, so we will try to we'll look for the compulsory part of the general physical examination. You can work out your own scheme of examination for the GPE, but a simple scheme starts with examination of the hands. For the examination of the hands, you can start with examination of the nails, and for the nails you have to elevate the patient's hand to the level of your eyes. Now the angle between the nail and the nail bed, it should be less than 180 degrees, and if it is flattened out, you have first degree clubbing. If you have first degree clubbing, what you do is that you stabilize the finger of the patient with both your index fingers and place the thumb on one side, the other thumb on the other side, and as you press down, the other thumb feels for the fluctuation. if it is present. This is the second degree of clubbing. And then you can have the drumstick shape of the fingernails. The other things you can look for in the nails is for any splinter hemorrhages, which are vertical lines at the distal end of the nails. Or you can look for pitting or spoon-shaped nails, also known as coloonychia. Sometimes you have white nails, sometimes you have half and half nails, in which half is white and half is brown. As you have examined the nails, you can at the same time look at the dorsal aspect of the hand and look for any for the joints, the skin, any bony swellings, the tightness of the skin, or wasting of the small muscles of the hand. Then you can turn it to the other side. Here you can look for at the fingertips. You could look for cyanosis. And in case you are dealing with the cardiovascular system, that is, you think that there's something wrong with the cardiovascular system, you can look for the Osler's nodes, which are tender red nodules at the fingertips. You can also look for Janeway lesions in case of the cardiovascular system, which are red erythematous localized areas over the palm. Then in case you think that the patient has got some chronic liver disease, you can look at the root of the fingers for any thickening, which is the first sign of a dipotens contracture. You can look for palmar erythema, which is a generalized redness of the palms. So once you are finished with the hands, you can move on to the radial pulse. For the radial pulse, you have to pronate the hand, semi-pronate the hand, and with 3 fingers at the distal end of the radius, you have to feel the pulse. As you feel the pulse, you can compare it with the radial of the other side. At the same time, you have to look for the rate of the pulse, and you have to count it for 1 minute and find out the rate. You also have to look for whether the pulse is regular or irregular. If it is irregular, you find whether it's regularly irregular or it is irregularly irregular. Then you have to look for the character of the pulse, in which you have to look whether it's a slow rising pulse, which is a gradual increase in pressure of the pulse, or it is a collapsing pulse. For collapsing pulse, which is usually a high volume pulse, you curl your fingers around the wrist, support the patient's elbow with the other hand, and you look for the pulsations of the radial pulse beneath your fingers. And now you briskly elevate the arm and see whether you have a missed beat or not. So you can also look for other problems, for other types of characters of the pulse. Sometimes you have to look for the vessel wall. And what you do for the vessel wall is that you feel the pulse, the radial pulse, with 3 fingers. Then you feel the brachial pulse, obliterate the brachial pulse by pressure over the brachial artery, and with the 3 fingers of the radial pulse, you stabilize the radial vessel with the 2 fingers, and with the middle finger, you feel for the vessel wall. So if it feels like a cord, that means that the vessel wall is atherosclerotic. If you are going for the examination of the cardiovascular system, you would also like to feel the 2 radials to find out a radio-radial delay. You will have to feel the 2 brachials. For a brachial, you grasp the arm like this, and this is where you will feel the brachial under the thumb. You can feel it on the other side as well. Then you look for the carotids. You don't have to palpate both the carotids at the same time, or it can give rise to syncope to the patient. Especially in case of the in case of the cardiovascular system, you have to look for a radiofemoral delay. That is, you feel the radial and the femoral pulses at the same time. Then you have to feel for the popliteal pulse, in which you dip your fingers into the fossa and feel for the popliteal pulse on one side and popliteal pulse on the other side. Then you have to look for the posterior tibial pulse, which is present behind the medial malleolus on the two sides, and the dorsalis medius, which is present at the root of the big toe. This is with reference to the cardiovascular system. Now, the next thing, as you move up from the hand, you'd like to take the blood pressure of the patient. After the blood pressure, move on to the face. And in the face, you would start from the eyes. In the eyes, you ask the patient to look down and you look for jaundice. But the most important point is that jaundice should be looked for in sunlight. Then you look at the conjunctiva to look for pallor. You look at the general appearance of the face, anything that is abnormal like ptosis or any malar flush or any other xanthelasma or any other such problem. You would like to use the torch to look for arcus senilis or arcus juvenalis in either case, and if it's a young patient. When you come to the mouth, use a disposable tongue depressor to look into the mouth, orodental hygiene, the tongue, the teeth, any cyanosis or any mouth ulcers. Patient, which is also one of the important vital signs, and you look at the JVP. For the JVP, you have to elevate the patient to an angle of 45, and you look at the JVP, which usually is not visible in the form of a lumen. It is usually visible in the form of a pulsation, and the pulsations are three of them: A, C, and the V waves. The external jugular is usually visible in the form of a lumen, a dilated lumen, while the internal jugular is visible in the form of a pulsation here. Now you have to differentiate between the carotids and the JVP. For there are certain points which go in favor that the pulsation is a carotid pulsation or it is a JVP. The carotid pulsation would be single, while the JVP will have the A, C, and the V waves. The carotid pulsation would have an outward movement, while the JVP will have an inward movement. And the carotid pulsation will be felt and it cannot be obliterated. While the JVP, you cannot feel the JVP and you can obliterate the JVP by gentle pressure. In case it is elevated, you can find out, you look at the upper level of the JVP and you feel for the manubrium sterni. Now at the manubrium sterni to the JVP, to the upper level of the JVP, you find out how many centimeters it is elevated, and you can make out that it is elevated so many centimeters above the sternal angle. Then you have to feel for the lymph nodes. You ask the patient to sit up and you examine the lymph nodes, preferably from behind. The angle of the jaw for the submandibular group, then in front of the ear for the preauricular group, behind the ear for the posterior auricular group, the occipital group, the upper deep cervical. go downwards to feel for the lower deep cervical and the supraclavicular lymph nodes. Dip your fingers behind the medial border of the sternomastoid to feel for the troisés lymph node. At the same time, you can ask the patient to swallow and feel for the thyroid gland, because thyroid gland will start moving on deglutition. Then you also auscultate the thyroid gland if it is enlarged for a bruit over the thyroid gland. And while auscultation, you ask the patient to hold the breath. Then you come to the axilla and you feel for the axillary lymph nodes. For feeling the axillary lymph nodes of the right arm, you have to do it with the left arm. Support the arm of the patient over your shoulder and insert your fingers into the axilla. Feel for the medial wall, lateral wall, posterior wall, and for the lymph nodes along with them. Similarly, for feeling the lymph nodes of the other side, you have to support the arm and insert your fingers into the axilla. Then you have to feel for the lymph nodes.
There is a chain that goes parallel to the inguinal ligament, and there is another chain that goes vertical to the inguinal ligament.
Lymph nodes. Similarly, you have the popliteal lymph nodes in the popliteal fossa, and finally, you can look for the pedal edema. And that would sort of complete your compulsory part of the general physical examination.